Neurology Quiz number 120. Describe the etiology, pathogenesis, and clinical features of MOGAD. This is part 1 of 2. Part 2 will discuss investigations, treatment, and prognosis. Pathogenesis. MOG is a component of myelin present on the oligodendrocyte surface and is highly immunogenic. The presence of anti-MOG antibodies in the body leads to MOGAD. This is an autoimmune inflammatory disorder characterized by CNS demyelination. Pathologically, there is perivenous and confluent demyelination, and cortical demyelination is frequently seen. Typically, there is a CD4 positive T cell inflammatory reaction with granulocytic inflammation. Complement deposition is also noted. These are slides of brain tissue. On the left is a case of ADEM showing perivenous demyelination, and on the right is a case of MOGAD showing confluent and perivenous demyelination. Epidemiology. The incidence is 1.6 to 3.4 million person years. In Europe, there is no major sex difference, in contrast to NMOSD with female predominance. It is more common in children, 35% of cases, with a second peak in young and mid-adulthood. It is described primarily in Caucasians. Most frequent manifestations in children include ADEM, optic neuritis, and transverse myelitis. Most common manifestations in adults include optic neuritis. The course can be monophasic or relapsing. Up to 50% may have a monophasic course, and identifying such patients can help avoid unnecessary treatment. Triggers and associations. It can be triggered by infection, usually viral, very rarely occurs post-vaccination. It is not strongly linked to systemic autoimmune diseases or antibodies, in contrast to NMOSD. There may be rare co-occurrence with anti-NMDA receptor encephalitis. There may be rare association with malignancy. Pregnancy may reduce relapse risk. Clinical features include the following. A. Optic neuritis. This is the most common manifestation of MOGAD, occurring in 40% of pediatric patients and 55% of adults. It is frequently bilateral and recurrent. Visual loss is severe at nadir, but good recovery, which is better than recovery in NMOSD. Headache is frequently associated with optic neuritis. On examination, optic disc edema and peripapillary hemorrhages are noted. MRI shows long anterior segment optic nerve lesions with more than 50% of the nerve affected in more than 85%, often with enhancement of optic nerve sheath, also known as perineural enhancement. In MS, typically less than 50% of the nerve is involved. Optic chiasm is involved in 10 to 15%. Isolated chiasm involvement is more suggestive of NMOSD. Risk of cumulative vision loss with relapses is seen. Patients with optic neuritis are usually persistently seropositive with a relapsing course. Myelitis can occur concurrently or sequentially with optic neuritis. This figure shows MRI features of optic neuritis. In the top images on the left is a corneal T2 MRI showing left optic nerve T2 hyperintensity. And on the right side in the top image is unilateral right-sided longitudinally extensive optic neuritis with associated T2 hyperintensity and swelling. In the bottom image on the left is a corneal T2 fat suppression MRI, which shows bilateral optic neuritis with marked T2 hyperintensity. And on the right in the bottom image is bilateral longitudinally extensive optic neuritis with gadolinium enhancement. This figure on the left shows right optic perineuritis with optic nerve sheath inflammation and enhancement, and on the left shows extension of enhancement into the intraorbital fat. This figure shows the difference in visual pathway involvement in MOGAD, NMOSD, and multiple sclerosis. A is MOGAD. Typical features include bilaterally longitudinally extensive optic neuritis with optic disc swelling, involvement of the retrobulbar segment of the optic nerve, and optic nerve sheath involvement or perineuritis. B is NMOSD with longitudinally extensive optic neuritis with optic chiasm and optic tract involvement. And C is multiple sclerosis with focal optic neuritis. Another feature of MOGAD is B. myelitis. This can occur alone or in association with other phenotypes. Viral prodrome is often associated. MRI shows longitudinally extensive spinal cord lesions in the majority. These can occur in isolation or with additional longitudinally extensive or short lesions. Isolated short lesions are less common and most suggestive of MS. The myelitis has a predilection for the conus medullaris, which explains the high frequency of sphincter and sexual dysfunction. On axial images, lesions involve the central gray matter called the H sign in up to 75%, and in 1/3 may be restricted to the gray matter and form a sagittal line known as the ventral sagittal line sign. Gadolinium enhancement occurs in 50% but tends to be faint and patchy and less avid than in MS or NMOSD, both of which can also have ring enhancement. Leptomeningeal enhancement can occur and extend to the chordae equina and nerve roots. Spinal MRI lesions may occur without clinical evidence of myelitis. This figure shows spinal cord MRI features in patients with MOGAD. In A1 is a longitudinally extensive T2 hyperintense lesion involving the conus medullaris on sagittal images. In A2 is a T2 hyperintensity restricted to the gray matter forming an H sign on the axial view. And A3 and A4 show leptomeningeal enhancement but no cord parenchymal enhancement on T1 post-gadolinium images. The next clinical feature is C, the NMOSD phenotype. Some patients with MOGAD meet clinical criteria for NMOSD. 10 to 40% of patients with seronegative NMOSD are anti-MOG antibody positive. Patients with the NMOSD phenotype most often have optic neuritis and myelitis. The area postrema syndrome is unlikely to be due to anti-MAG antibody. Another clinical presentation is acute disseminated encephalomyelitis or ADEM. This is the most common initial presentation of MOGAD in children, noted in almost 70% of pediatric cases. It is especially common in children below 10 years of age. It is a clinical syndrome characterized by encephalopathy, not explained by fever, systemic illness, or postictal features. Clinical features include fever, encephalopathy, headache, seizures, as well as brainstem and cerebellar dysfunction. MRI brain reveals bilateral supratentorial brain lesions, which affect both subcortical and deep white matter. There is involvement of deep gray nuclei, including the basal ganglia and thalamus. MRI lesions are usually large, more than 2 centimeters, poorly demarcated and best visualized on FLAIR sequences. Active lesions often enhance. ADEM is usually monophasic, but a subset of patients can develop relapsing disease. These are actual FLAIR MRI sequences of a 3-year-old female with MOG antibody positive ADEM, showing bilateral white matter and deep gray matter thalamic lesions. Next clinical feature is focal encephalitis or flames. This is a rare manifestation of MOGAD. Such patients present with decreased consciousness, focal weakness, and seizures or status epilepticus. MRI reveals hyperintense cortical flare lesions that are usually unilateral, appear swollen, and may demonstrate associated leptomeningeal enhancement. This syndrome has also been labeled flames or flare hyperintense lesions in anti-MOG associated encephalitis with seizures. This figure shows MRI in a case of flames. This is a flared MRI of the brain in a 29-year-old woman with positive anti-MOG antibodies who developed headache, fever, convulsions, and right hemiparesis. The MRI shows hyperintense cortical lesions on the left side. This is brain imaging in another case of flames. The image on the left is a flared MRI showing cortical swelling and hyperintensity of the left frontal cortex and adjacent sulci. And on the right is an axial T1 weighted image post-gadolinium, which shows corresponding leptomeningeal enhancement. Another clinical feature is F, atypical encephalitis. A small number of MOGAD patients may have an encephalitis-like illness but do not meet criteria for ADEM or flames. These patients may present with altered consciousness, seizures, or a cerebellar/brainstem syndrome. MRI abnormalities include bilateral cortical and/or deep gray matter lesions. However, some patients have minimal changes on brain imaging despite dramatic clinical features such as refractory status epilepticus. Another clinical presentation can be clippers or chronic lymphocytic inflammation with pontine perivascular enhancement responsive to steroids. Clippers is a relapsing subacute brainstem syndrome presenting with symptoms such as ataxia, diplopia, dysarthria, and altered facial sensation. MRI shows punctate or curvilinear gadolinium enhancement in the pons and adjacent cerebellum. Neuropathological examination shows a perivascular lymphocytic inflammation that may involve both white and gray matter with a CD4 T-cell predominance. Clinical symptoms and MRI abnormalities respond well to high-dose IV steroids, but long-term oral steroids or steroid-sparing agents are often needed to prevent relapses. Anti-MOG antibodies have been identified in cases that meet criteria for clippers. This is an MRI of a patient with clippers which shows T2-weighted hyperintensities in the brainstem and cerebellar peduncles on the left, with a similar pattern of enhancement on the right. Finally, clinical presentation may resemble a progressive leukodystrophy. Some patients, especially children with the ADEM phenotype, may exhibit progressive deterioration in addition to discrete relapses. In such cases, the brain MRI may have an appearance that resembles a genetic leukodystrophy. Such patients tend to have high levels of disability and poor recovery, but immunotherapy may be helpful.